this time in their life is a wonderful opportunity. So rather than dreading it, I think it's a good opportunity for women. And central, first and foremost, before any kind of medication, we talk about lifestyle factors that could be changed. Women who undergo premature ovarian failure, these are the women who really need hormone replacement therapy.
This is the Transformational Life Consulting Podcast with Deepa Grandin, MD, where Christians like you get the practical support and tools you need to build your spiritual, mental, and physical well-being, and to guide you on your journey to health and wholeness based on evidence-based science and God's Word. I am your host, Dr. Deepa Grandin. Menopause is a natural physiological process that marks the end of a woman's reproductive years. It occurs when the ovaries stop producing eggs and the levels of the hormones estrogen and progesterone decline. So this can happen typically between the ages of 45 and 55, but everyone's different. Sometimes it can happen earlier, sometimes it can happen later. So while most women, they have mild to no symptoms, there's also a good percentage of women that struggle with hot flashes, night sweats, trouble sleeping, joint and muscle discomfort, pain during sex, moodiness, irritability, forgetfulness, difficulty concentrating, or just a combination of any of these. So in today's podcast, we will zone in on potential natural as well as hormonal solutions to the symptoms that arise during the menopausal phase of a woman's life. To discuss this important topic, we are very fortunate to have Dr. Malini Sharma, who is a board-certified obstetrician gynecologist. Dr. Sharma received her medical degree from University of London, England. She completed her postgraduate training in Northwest London Deanery. Through her tenure, Dr. Sharma has specialized in obstetrics and gynecology, completing over 3,000 gynecological operations. So, Dr. Sharma, we are very grateful for your time and expertise. Do you mind sharing with us a little bit about yourself? What got you interested in OB-GYN?
Deepa, thank you so much for inviting me to be part of your podcast. It's a great honor to talk about something that I'm really passionate about. So thank you for flying the flag for this important area for all women. Well, I've actually been a doctor for more years than I care to remember. 30 years, if you're going to ask. And I came into obstetrics and gynecology almost by default. I was convinced during my training that I would be an internal medicine physician. And after graduating, I pursued internal medicine, which is a wonderful, wonderful area. But I found that it wasn't giving me the satisfaction. And a little clue to me was when I would walk past the delivery suite, I'd have a little bit of jealousy that I wasn't part of what was going on in that area. So I had a little bit of a career crisis moment thinking, this isn't doing it for me. What am I going to do? So I bit the bullet. And literally 29 years ago almost, I stepped foot in the delivery suite and I honestly never looked back. It's such a fulfilling specialty. There's a huge diversity of what we do, from obstetrics, delivering babies, to gynecology, and all aspects of women's healthcare, which I find extremely fulfilling. And, up to this time, I still get a lot of enjoyment from my work and communicating with women and hopefully fulfilling their medical needs and helping them through their various journeys. And in the last few years, I've developed a huge interest in menopause, hormonal health. And you and I both know about lifestyle medicine, which is a huge focus in my specialty now. So that's kind of a brief nutshell of where I'm ending up practicing today.
Yeah, I can definitely see that passion shining through when you talk about obstetrics, gynecology, and lifestyle. And we had actually spoken several times about having you on the show to talk about lifestyle and women's
Right.
health, because I really feel like we don't have enough um, spotlight shed on this area. And a lot of women suffer, and not even realize that that's something they can talk to their doctors about and try to get relief. So I'm very excited to have you on the podcast so we can talk about some of the common issues that women face and also some of the stigma around hormonal treatment.
Wow.
Yeah, and why people should sometimes consider depending on circumstances. So let's just start with basics. So what exactly is menopause? I know I gave a brief introduction, but it'd be nice to hear
Yeah.
in your words. And what age does this commonly occur?
So, as you quite rightly pointed out, it's essentially the end of reproductive life. Um, Women generally have menstruation from the start, which is called menarche, and that can occur from the age of 10, 12, 14, that sort of age. Obviously, we know that in some young ladies, it can be earlier. And then for about 40 years on average, women will have menstruation during which they're considered to be fertile. The end of reproductive life is essentially where we reach menopause. And when women hit the final menstrual period, that's not called menopause. It's actually the year following when a woman has had no vaginal bleeding that we define them as being menopausal. Now, within that sphere, we know that women within the age from 40 onwards, menstruation can start to change. Um, and in the years running up to the final menstrual period, a lot of hormonal fluctuations can occur. And in that time, they may have a variety of symptoms. And we'll talk about these as we go along. Um, the first typical sign that a woman might experience is irregularity of the menstrual cycle. Now, on average, a lot of women will have a regular menstrual cycle every month. There are a number of hormone conditions that can be associated with irregular menstruation in early years. But from the 40s onwards, typically, women are more likely to experience menstrual changes. And what we call the few years in the run up to menopause is called the menopause transition. And it's defined as early and late menopause transition. And in the early phase, women may experience more irregularity of their cycle. What I mean by that is if, for example, a woman has been used to having a 28-day cycle, for example, it may suddenly come erratic, maybe every 5 to 6 weeks, even longer, sometimes shorter. And as women move through the early phase to the later phase of menopause transition, other symptoms can start to develop. Symptoms such as the typical hot flashes we all hear about, and night sweats, mood changes, brain fog. And if we look at globally, you're quite right. Typically, menopause can occur in the majority of women between the ages of 45 and 55. The average age in the UK, which I know because that's where I trained, is 51. That's the average age of menopause. We consider it as normal menopausal aging anytime from 40. And women who experience cessation of menstruation for good under the age of 40, that's called premature ovarian insufficiency or premature menopause. I think we're going to talk a little bit about that later on. So it can affect women in a variety of ways. And you mentioned that some women have symptoms. And if you look at the statistics, around 80% of women will experience symptoms in one form or other. And if you look at the list of potential symptoms that women may experience, it's vast. Over 40 symptoms are well documented in menopause. And these symptoms can present to a variety of doctors. For example, menstrual irregularity may come to somebody like me, a gynecologist. You might see, as an internal medicine physician, you might see somebody who's having joint aches and pains. Other presentations may include mood changes, anxiety, palpitations, depression. Emotional dysregulation is extremely common. Our rheumatology colleagues may see ladies with joint aches and pains, muscular pains. I'm going to tell you a little about me personally. I'm a lady of menopausal years. And my menopausal transition, I sailed through until I started having joint pains. I thought, this is very strange. And to cut a long story short, those aches and pains actually got better when I started hormone replacement therapy. So I'm a big fan of it personally. And it really, that was the way that I presented with symptoms.
So thanks for sharing that, because we don't always consider the wide or vast variety of manifestations of your hormonal cessation or decrease, right? We are taught in medical school, like the hot flashes and the weight gain and the trouble sleeping. But things that we don't always put two and two together is when you become forgetful, irritable, difficulty concentrating. All of those are also signs of menopause. So you did touch on some of the psychosocial and physical changes. Can you go into a little bit more detail as to what can a woman expect, especially if she's in this premenopausal or menopause transition phase, so she can at least be aware. And so when it does happen, it doesn't take her by surprise.
Right. So we alluded to menstrual regularity changes. That's probably the first clue that a lot of women will experience.
Yeah.
Well documented is what we call vasomotor symptoms. Those are the hot flashes where women typically describe a surge of heat coursing through their bodies. And a lot of women see this as a social nightmare because suddenly they're carrying on with their business and they just feel this heat ascend in their bodies. And it's quite dramatic. And for some ladies, it's mild. For a lot of women, it's severe. I mentioned up to 80% of women will experience symptoms, and a quarter of those are described as severe. So women can find these symptoms quite debilitating and socially awkward. The night sweats. In night sweats, women can wake up drenched in sweat. So much so that they may have to change bed clothing. They have to have the air conditioning on really low to manage their symptoms. And sometimes this causes a discrepancy with partner, for example, in terms of keeping the room cool. And as a result of this, sleep disturbance can result. Sleep disturbance can occur irrespective of the night sweats. And as a result of that, if you are having disturbed sleep during the night, it's going to affect your day-to-day alertness, daytime tiredness, brain fogginess. brain fogginess is extremely common. Women will report this. As we age and the hormone estrogen starts to decline, women may notice weight gain despite doing the same activities, eating the same kind of foods. It's one of the biggest complaints women have. And typically, the weight tends to be gained around the middle section. And a lot of women have this problem or relate to it typically. We don't know typically why, but we do understand that in women whose hormone levels are dropping, there are changes into blood fat, blood lipids. We also know that there is an increase in what we call insulin resistance, so the way our bodies handle glucose. And we talked about other symptoms, including palpitations, musculoskeletal symptoms such as joint aches, joint pains, muscular aches, backaches. All of these are very, very common. And there are a whole host of additional symptoms that women can describe that have been attributed to menopause transition. Very often, women have a combination of symptoms.
Yeah.
Typically, a lot of women are very fearful about menopause because of the implications of the end of reproductive life. And I've had patients say to me things that really give me insight to their psyche at the time. And some women say things like, I don't feel like a woman anymore. Mm-hmm. And it kind of blows my mind that it's such culturally seen to be something that's taboo in the past. It has been. If you think about our grandparents' generation, nobody spoke about menopause. And I often ask my ladies, do you know what age your mother or your grandmother went through menopause? Nobody has an idea about that because it wasn't spoken about. So I think more and more we're talking about it, which has got to be a good thing, because the more we share our experiences, the more we can learn about what sort of things to expect.
Yeah. So I'm a runner, and I've always loved, I mean, I've not always loved to run, but since I've had my kids, it was the way for me to keep my weight in check. But I noticed, like, when I became premenopausal, menopausal phase, that I needed to do more like body strengthening type workout, like Pilates, mobility, to, like, the central fat that you were talking about, really toning your muscle, and doing these weight resistance type workouts have helped in maintaining the tone, and also muscle volume, because we underestimate how much insulin resistance. It's almost like a direct correlation with muscle volume, because muscle utilizes the most amount of sugar. So I always tell my coaching clients as well as my patients, it's great that you're doing aerobics for the cardiorespiratory part, but don't neglect the weight resistance, because that will really, especially if you have a history of diabetes, insulin resistance is a huge factor in that. And then making the time to do the weight resistance is so important to maintain your muscle volume, because sarcopenia is another problem as we age and with the hormonal drop and things like that. So what are some lifestyle measures that can be used to alleviate some of the menopausal symptoms that you mentioned?
Mm-hmm. In actual fact, I really focus on lifestyle measures first and foremost. And women who come to see me with their symptoms, I really try and make them see that this time in their life is a wonderful opportunity. So rather than dreading it, I think it's a good opportunity for women to say, hang on, I'm reaching a transition. I'm reaching another phase of my life. And I really want women to feel empowered to make changes that will see them through a healthy menopausal life. And central, first and foremost, before any kind of medication, we talk about lifestyle factors that could be changed. And you alluded to some of them. Diet, first and foremost. Having a healthful diet. We talk about a healthy plate model to give guidance on the type of foods that we recommend. I'm sure you must have alluded to that in previous talks. Concentrating on eating the rainbow, you've heard that term before. The more colors you incorporate it into your diet, the better. You're allowing your body to get antioxidant rich foods, which help combat inflammatory changes, which can certainly increase in the menopause transition. Exercise is essential, and the type of exercise is absolutely crucial in what we advise our ladies. Any exercise is great exercise, and I encourage women to pursue the activity that they love best. But if they can incorporate weight training and resistance exercise, not only does it maintain muscle mass, but it helps improve bone integrity, because as estrogen levels drop, so does bone quality and bone integrity. And that bone thinning really needs to be avoided, and exercise definitely helps. So resistance training, weight bearing exercises, weight training are going to help women. I don't know if I'm sure you're certainly familiar with Stacey Sims, the exercise physiologist, who's published extensively about menopause health and how to improve physical activity, specifically focused to peri and postmenopausal women. I'd encourage your listeners to delve into her literature. It really gives some good guidance on the type of workouts that would be beneficial.
Well, that's good to know.
So we talk about exercise, diet, sleep. Now, we all have factors in our life that affect our sleep. Work patterns, work stresses, screen time. All of these have an implication and effect on our sleep quality, our sleep duration. And more, there's a huge amount of emphasis on the importance of sleep in recovery, regeneration, healing. So looking at bedtime regimes is extremely important. Avoiding screen time in the couple of hours before going to bed. Eating meals at least 2 to 3 hour window before heading to bed. If you're going to do workouts, again, having a window of time before going to bed, not doing it an hour or so before bedtime.
Right.
Alcohol as a bearing. So we generally would advise, if you are a consumer of alcohol, looking at your intake, because we know certainly alcohol can aggravate the hot flushes and the night sweats.
Yeah.
And stress management, because usually women in midlife have so much to juggle. Career pressures, family pressures, children leaving home, going to university. A lot of factors affect women around this time of their lives. So looking at coping strategies that may be able to help is a huge focus.
Yeah, I think that's so important, like what you mentioned about the sleep, because I have so many clients, they don't realize how warm they're keeping their room. And that does play a role when they're having these night sweats. They have the night sweats, the room is not cool enough, sometimes it's not dark enough. And yes, electronics, watching TV in their room. The sleep hygiene is so important.
Right.
And a lot of them don't realize the importance of the bedtime routine just to wind down. Because as you rightly pointed out about all the stress that comes at this age in our life, taking care of elderly parents, taking care of kids going to college, and then on top of that, work stress. So being so mindful of turning your brain off at least 30 minutes to an hour before you go to bed is so crucial.
Right.
And having that discussion with your partner about how cool you need to keep the room, and how dark, and making sure electronics, I mean, those are such important discussions to have. And then also, the importance of community, because sometimes women feel so alone because they're all focused on taking care of other people. They don't spend time with their friends or have that community. So you feel like you're not alone in the struggles that you're facing. So, yeah, I think all of those are so crucial, and important lifestyle measures to combat the menopausal symptoms. So let's just move and transition to the menopausal hormone therapy. So to be honest, like, because I have a family history of heart disease and strokes and things like that, I have always been very wary about taking the hormone menopausal therapy. Menopausal hormone therapy, I think it's almost also called MHT. Um, and then I'm sure you're familiar with all the publications that came out like what, 10, 15 years ago about the cardiovascular effects of hormonal therapy that, made more physicians wary about prescribing it to
Yeah.
women,
Mhm.
especially with a family history of heart disease. So, can you shed some light on the pros and cons of the MHT, and when should this be considered?
Right. So you're right. There has been a lot of controversy about hormone therapy. And that really stemmed, believe it or not, it was around 2002, with the massive Women's Health Initiative study and Million Women study. So these are sort of studies that really shed a bad light on hormone therapy, showing an excess of breast cancer risk and cardiovascular disease. And as a result of that, the prescribing of hormone therapy just fell right down, to the point that women were avoiding it significantly, yet suffering. A lot of work has been done in the 20 years since to tease out the information that was effectively misrepresented. And what I mean by that is that when you essentially look at these studies, the hormone therapy that was being given was in doses at much higher levels that we would currently use. And the population that was studied was significantly older than the age group in whom we would now recommend hormone therapy to. And the plainest fact is that if women, the majority of women are considered at low risk of breast cancer. That's one of the big concerns that women have. And if a woman is to consider hormone therapy in the menopause transition and in early menopause, we know that the benefits of HRT or hormone therapy far outweigh any potential risk in the first 5 years of use. We also know that the longer you use hormone therapy, risks gradually increase, partly because of the hormone therapy, but partly because of the aging process. So, whenever I sit down with a patient and discuss whether hormone therapy is indicated and whether it should be initiated, we address the woman's health history, Are there any risk factors in their history, such as a history of breast cancer, stroke, thrombosis, chronic disease of any kind? And you're right, hormone therapy is not suitable for everybody. And if on balance we decide that it's a reasonable option based on the degree of symptoms that they are experiencing, we discuss the safety. And really, what women need is a solution to their symptoms that they're experiencing at that time. And like I said, we know that it's generally safe in the menopause transition and early menopause for up to 5 years. After that time, health risks increase, and it requires an ongoing conversation to discuss the benefits against the risks.
Yeah, so the shared decision making,
Right.
and just understanding how much of a benefit versus risk, that makes total sense. So, what would you consider are strong contraindications to MHT?
Yeah. So, if a woman has a breast cancer history, generally that's a contraindication. There are some women who have got a strong family history and carry a gene that increases their risk, BRCA gene being one of them.
Yeah.
Now, while that's not an absolute contraindication, it's a relative contraindication. And we always make sure that before we have any counseling, women are up to date with breast screening, pap smears, and the like. If a woman is having undiagnosed or unexplained abnormal vaginal bleeding, that warrants investigation before considering hormone therapy. Other medical conditions, if a woman has a history of thrombosis or stroke, it's generally a conversation that would require teasing out what the reason is behind those conditions before we consider whether they're suitable. But generally, they're relative contraindications. Heart disease is an interesting one because we know that in certain women who have had a heart attack, they will be suitable to have hormone therapy because we know that there is a beneficial effect of estrogen replacement on blood vessels. So while the contraindications are obvious, the personal history of breast cancer or undiagnosed breast lump, abnormal bleeding, thrombosis history, there are some relative contraindications. So women who have significant medical histories with multiple health complaints such as obesity, diabetes, smoking, these are conditions that increase health risks. So we'd have to be very careful about teasing out who might be suitable.
Okay. And what are some commonly used regimens for MH?
Right. So the main hormone that we need to consider for hormone therapy is estrogen. And estrogen can be delivered by tablets, through the skin, in a vaginal route, and through the skin, it can be either a patch, a gel, a spray. Now, if a woman still has her uterus, we add progestin. Progestin is the hormone that keeps the uterus lining healthy. And so it's generally a combination of therapies, estrogen and progestin. The progestin can be given by mouth or through an IUD, a hormone IUD. And these are the main routes of progestin. And the regime that we follow is really dependent on when hormone therapy needs to be considered. So if a woman is still having periods, we may give a regime that brings on a monthly bleed. If menstruation has stopped altogether, it may be suitable to give both estrogen and progestin together, so there is no bleeding. And actually, a lot of women are happy to have no bleeding. So it's suitable for women who've already reached menopause. So we tailor the management according to a woman's preference. Some ladies like a patch because they can put it on, forget about it, change it twice a week. Some ladies prefer a tablet, but if we look at the safety data, we prefer to give estrogen through the skin. We know that it significantly decreases the risk of blood clots. It decreases the risk of thrombosis.
Got it.
And we also try and choose formulations that are have a more similar structure to the body's own hormones.
Yeah.
You've heard the term bioidentical.
Right.
And we use estradiol, which is the form of estrogen that we know has a higher safety profile. And for the progestin, one of the safest types of progestin is a plant-based progestin called micronized progesterone. And that is very, very similar to what our own bodies make. Other progestins tend to be synthetic, and they have additional side effects.
Oh, that's something new I've learned. I did not know you could have a plant-based progestin. I didn't know plants made it.
Yeah.
That's fascinating. So is there a role for MHT in preventing chronic diseases associated with aging?
Nice question.
Yeah.
So statistically, heart disease is one of the biggest killers in women. And it tends to present differently in women than it does in men. And we know that there is this window of opportunity that can be embraced for us starting hormone therapy in women to help reduce cardiovascular risk. Hormone therapy can be used to help mitigate some of those risks. Why? I alluded to the estrogen having a beneficial effect on blood vessel integrity, and it can help decrease atheroma formation. We know the combination of statin therapy with hormone therapy can be a really good combination at helping decrease risk. So for women who have additional risk factors for cardiac disease, such as hypertension, it's an opportunity to discuss whether hormone therapy will help mitigate some of their risk.
Good.
And this window of opportunity is where we need to be discussing it with women. And that window of opportunity is considered to be within that 10-year window of menopause. Beyond that 10-year window, the health risks increase, cardiac risk increases. So we tend not to consider hormone therapy for women in their 60s as initiating at that stage.
Sure.
So really, we as clinicians really need to be starting considering that conversation earlier for women.
How about insulin resistance and obesity, that kind of thing? Does it help mitigate some of those?
Now, that's a really good question. And it's a conversation that I have. I think we need to be realistic with our expectations. There is evidence that menopause affects the lipid balance in terms of increasing LDL cholesterol. We know that. And in theory, we know that estrogen replacement can help improve triglycerides and lipid balance. The reality of it is that hormone therapy per se hasn't been shown to demonstrate a positive effect on the lipid balance, but theoretically it can do. So the formulations that we use are not sort of dedicated to improve your lipids like a statin is, for example. So I really think so in terms of cardiovascular disease, there is a discussion to be had as to what your current risks are or what our patients' current risks are and whether this would be a beneficial addition. Other chronic conditions, I alluded to osteoporosis and osteoporosis-related fractures. And if women have a family history of a close relative having osteoporosis, if they have had long-term steroid therapy, for example, we know that's a potential risk factor for decreased bone density. There are many other conditions that can affect bone integrity. It's worth teasing out the prior medical history because realistically, if we can offer something that improves bone integrity, we should be grabbing that opportunity to discuss. Other chronic conditions. I can think of that there's a category of women who have, if women have a prior history of depression, we know that during the menopause transition, depressive symptoms can prevail, anxiety, depression. And we know that hormone therapy, if instigated during that phase, can significantly improve the mental health symptoms that can be associated. I saw a patient today, actually, who I've known for 2.5 years now. And when we first met, she was going through the transition, and the anxiety and depression were incredible. She was in tears when we first met, and she had a prior history of anxiety and depression. She was the one who instigated the conversation about hormone therapy, the reason she came to see me, because in addition to the mental health symptoms, she was having the hot flushes and night sweats. So we talked about all of her symptoms and agreed that there was definitely a role for hormone therapy, but because of her prior history, we discussed referral to see a psychiatrist and have counseling. And today we met. I've been seeing her regularly over the last couple of years, but within a short space of time of having the right mental health therapy with medication and counseling, as well as the hormone therapy, she was a different woman within, I think, 6 months or so of therapy. We had to titrate her therapy to make it optimal for her, but we got there, and she is living her best life according to what she said to me today, which is really affirming and knowing that we're on the right track for her.
Yeah, that's a beautiful story. Do you know of any data regarding dementia and hormone therapy?
Oh, great study. Great question. There's a lot of work going on about it at the moment. And I think it was 2023. There was a study that was published in Europe looking at it was more of an epidemiological study that reported that there was an increase in the risk in hormone therapy users of dementia. So that caused a huge amount of controversy. And the data is specifically being looked at now to try and answer that question more fully. So there's a lot of work that's ongoing. So watch this space. I think more and more information will be coming out in the coming months and years. Right now, it's not an indication. So if you have a family history, it's not an indication for us to think about hormone therapy. I mentioned the brain fog that a lot of women experience. And we know that hormone therapy can help improve that brain fog. There is a special patient group that we alluded to earlier, women who undergo premature ovarian failure or insufficiency. And these are the women who are under the age of 40. And these are the women who really need hormone replacement therapy. What they need is, when the ovaries stop working early, it has significant effects on bone, we talked about, heart disease risk, and brain health. Those women are at increased risk of dementia. And we know starting hormone therapy in that group of women and continuing until the natural age that they would have reached menopause, so early 50s, is super safe, and it can help mitigate those risks. So if anybody is concerned about menopause symptoms under the age of 40, it is literally a no-brainer. It needs to be discussed, because what we want to do is help reduce future health risks in terms of those three important areas: brain health, heart health, and bone health.
Yeah. I think that also brings to my mind another group of patients who don't fall in the menopausal category, but the eating disorder, very young patients stop menstruating,
Right.
and how much of a risk they are in. So it's good points to be thinking about even for them. So you did, I think this is a good segue for the next question about the premature ovarian insufficiency, which you alluded to throughout our discussion now. So the brain health, the heart health, the bone health, the impact it has on women's health. Is there anything else that you would like to add?
Yeah. So when a young woman, so the earliest stage I've seen this happen is a woman in her 20s, early 20s.
Yeah.
And you imagine it's a devastating diagnosis, devastating. The youngest patient I had was 22. And it's not a diagnosis that you would expect to have to share to a patient. Because at 22, you've got your life in front of you. You're thinking about marriage, you're thinking about pregnancy, you're thinking about having a family of your own. And when you go to see a doctor and you're told that your ovarian hormones show that you're going through effectively an early menopause, it has huge psychological implications.
Yeah.
We alluded to the benefits of hormone therapy, but let's not forget the psychological impact it has.
Yeah.
Because you're telling that woman effectively you can't have a natural pregnancy. There is a lot of work going on in the fertility setting, looking at preservation of ovarian tissue, and it's still early phases. About looking at ovarian tissue transplant, for example. So it's not something that is commonly done, but it's something to think about, that may watch this space for the future. It may be an opportunity for women. So currently, for women who have early ovarian failure, we don't always know the reason why. Sometimes it's familial. There may be a family history of somebody having early menopause. Sometimes it's due to other factors, such as early childhood cancers, for example. Women who've been exposed to chemotherapy or radiotherapy early in their lives because of childhood cancers. Sometimes that can affect ovarian function and lead to early failure. Sometimes you and I both have an interest in functional medicine. There are what we call endocrine disruptors, chemicals in our food, in our environment, that could potentially have an effect on ovarian function. So there are a number of reasons for premature ovarian insufficiency or early menopause that we don't fully appreciate. But the important thing is to understand the impact of what it has on that particular woman and how we can support them. Hormone replacement is a crucial part of that.
Yeah.
That scenario, and psychological support to help them come to terms with what that means for their future reproductivity or lack of reproductivity. So that's a whole other deep conversation.
Yeah, I'm pretty sure it is. So, how does cognitive behavior therapy reduce the impact of vasomotor symptoms?
Right. So, cognitive behavioral therapy is well recognized as an evidence-based treatment. It's recommended for not just the vasomotor symptoms, but also the psychological symptoms. And there's good, robust evidence to suggest that it works well for women. And it's essentially a therapy that is based on understanding our thoughts in relation to the symptoms that we experience and helping us understand the cycle that occurs. Those thoughts lead to feelings. And women can get into quite a challenging situation in dealing with their symptoms. So in certain situations, it may be a first line option to consider, particularly for those women who may not be suitable for hormone therapy. So it's an excellent option to think of and at least raise the discussion if a woman can have access to a provider who can teach them or lead them with CBT.
Yeah. So thanks, Melanie. You've shared so much great information with us. Is there anything else you'd like to share before we conclude?
So thank you so much for giving me the opportunity, first of all. And I hope that this discussion will allow women to feel empowered to start the discussion with their care providers to say, I'm having this symptom, I'm having whatever the symptoms may be. It's worth a discussion to explore what might be behind it. And always thinking about menopause being a possible explanation for the symptoms. And please, I'd encourage women to see this as a great opportunity to improve things in their life, to go through this next part of their life in a healthier phase.
Yeah, that's great advice. So anyway, thanks again, Melanie, and we look forward to having you in more of our podcasts and webinars in the future.
My great pleasure.